Xin chào quý vị đồng nghiệp, đón chào quý vị đồng nghiệp đến với chương trình webinar của chúng tôi. Chúng tôi rất là hân hạnh Trung tâm Quốc mắt quốc tế phương Đông cùng với phòng khám quốc tế Mỹ được sự kết hợp của công ty PCV rất là hân hạnh được chào đón quý vị đến với hội thảo ngày hôm nay. Thưa quý vị, nói về bệnh nAMD đó thì cách đây chừng khoảng 5-10 năm thôi thì chúng ta không có gặp nhiều. Không gặp nhiều không có nghĩa là cái bệnh lý này chúng ta không gặp mà không có nhiều ở Việt Nam, mà đơn thuần chỉ vì là cái thông tin về cái bệnh lý này và cái phương pháp điều trị cái bệnh lý này là chưa được phổ biến. Thì ngày nay chúng ta đã thấy là số lượng bệnh nhân đến với chúng ta rất là nhiều, và có một điều rất là may mắn là rất nhiều bệnh nhân đã biết được rằng là những cái bệnh lý liên quan đến tuổi già là hiện nay đã có phương pháp điều trị hiệu quả. Và cái hội thảo ngày hôm nay thì cũng nhằm vào cái mục đích là đem đến những thông tin mới nhất và cập nhật nhất đến với quý đồng nghiệp về các bệnh lý nAMD cũng như là điều trị PCV. Thưa quý vị, trong cái webinar ngày hôm nay thì chúng ta sẽ đi qua rất là nhiều cái chủ đề phải nói là nóng, tức là chúng ta sẽ tìm hiểu về cái vai trò của loại thuốc mà sắp ra trên thị trường, hiện nay đã được FDA công nhận ở Hoa Kỳ và chưa có ở Việt Nam, xem cái tác động của nó đối với cái việc điều trị PCV cũng như nAMD như thế nào. Chúng ta sẽ tìm hiểu xem là khi chúng ta điều trị nAMD thì còn cái lượng dịch dưới võng mạc thì nó ảnh hưởng đến như thế nào đến tiên lượng và cái phác đồ điều trị chúng ta. Chúng ta sẽ tìm hiểu xem là chúng ta khi giãn cách thì chúng ta giãn cách như thế nào và có cái điều trị cá thể hóa nào trong cái việc chúng ta điều trị giãn cách hay không. Đồng thời chúng ta cũng đánh giá được, cũng có các thông tin về việc sự khác biệt giữa điều trị PCV và nAMD trong cái hoàn cảnh hiện nay như thế nào. Thì đấy là những cái chủ đề mà chúng ta sẽ chúng ta sẽ có được các thông tin qua hội thảo ngày hôm nay. Thì ngày hôm nay tôi rất là hân hạnh mời được bác sĩ Kevin Wong từ Trung tâm mắt quốc tế Mỹ đến cùng trao đổi thảo luận với tôi trong cái buổi ngày hôm nay. Thì để cho cái hội thảo nó diễn ra một cách suôn sẻ thì tôi xin phép là chuyển qua ngôn ngữ tiếng Anh để có thể trao đổi với bác sĩ Kevin Wong. Và tôi rất là cảm ơn bác sĩ Huỳnh Võ Mai Quyên là người phiên dịch trong cái buổi hội thảo ngày hôm nay. So I'm very pleased and honored to have Dr. Kevin Wong with us today. I personally know Dr. Kevin Wong about 3 years ago, and I have a chance to see some of Dr. Kevin Wong's patients, and I really appreciate the way he approached his patients. He always approached with customized treatment for each patient. And I think it's very important to treat every patient differently because no patient is the same. And this information we also learned from the webinar today. I'd like to introduce a little bit about Dr. Kevin Wong. He had medical retina and uveitis subspecialty training at Tennant Eye Institute in Glasgow, Scotland, in the UK, the United Kingdom. He is a fellow of Royal College of Ophthalmologists and fellow of Royal College of Surgeons of Edinburgh. He was a consultant at the Uveitis Service, National Healthcare Service in Scotland, UK. He was a clinical lead diabetic eye disease, ocular vascular disease, and uveitis in Scotland, UK. He is an associate consultant, ocular inflammation and immunology and medical retina at Singapore National Eye Center, SNEC. And he is a lecturer, Glasgow Caledonian University, Scotland, UK, and a lecturer at Duke and US Medical School, Singapore. Thank you, Dr. Kevin Wong. Thank you for being with us today. So, Dr. Kevin Wong, when you treat AMD or PCV patients, what are the concerns that you face most often in your clinical practice?
Well, during the treatment of PCV and AMD patients, in the past, there used to be very strict guidelines and protocols for us to follow. Example, monthly treatment and then followed by 2 monthly injections on a 4-injection basis. However, as time progressed and treatment techniques improved, we now know that individualized treatments for each individual patient is very important in order to optimize the effectiveness of anti-VEGF treatments. In Vietnam especially, this is extremely important. Why is this so? Unfortunately, in Vietnam, ICG imaging is not readily available, and PDT treatment is not available at all. Patients have to travel afar to obtain PDT treatment for PCV, as well as PDT treatments for things like CSR. So in Vietnam, it's very important for us to optimize and individualize treatments for patients in order to ensure effectiveness of their treatment for PCV as well as nAMD. Other factors that are important for me in my clinical practice include retinal fluid. How do we use this important measuring, in inverted commas, factor to monitor patients' response, as well as to tweak and optimize patients' treatments to ensure effectiveness is maintained. Sometimes stubborn fluid residual or resides in the subretinal layer, and how do we manage and use this subretinal fluid or retinal fluid to help us guide us in further management of patients. Lastly, in the advent of COVID, which is a very real and present danger that we're all facing throughout the world, treatment as well as follow-up of patients may not be done in an efficient and timely manner all the time. Therefore, it is important for us to balance the number of injections in order to ensure treatments for these patients remain effective, to ensure good visual outcomes, as well as to balance their follow-up and treatment regime.
Thank you very much, Dr. Kevin Wong. When I talk to my patients, I always tell them this is a chronic disease. So it will prepare them to not only about the expecting the outcome, but also preparing for time and money that they have to follow along at least 5 or 10 years. Mm-hmm. So and there's another issue also, that is the burden of care. A patient when come to the clinic is normally they will not go there by themselves. They usually have to go with their relative, their son, their daughter. So the burden impact to the patient is huge. And all the modern technology or anti-VEGF agent all aim to reduce this burden in the treatment of AMD and PCV. So in this webinar, I think we have 4 presentations, and this will go from the pathogenesis to clinical fluid control to PCV, and how to do the treat and extend and customize the treatment for the patients. And the panelists are very famous. They are world-class panelists. So I would like to introduce the panelists of the webinar. First, Professor Nancy Holekamp. She's a professor of clinical ophthalmology and visual sciences at Washington University School of Medicine in St. Louis, Missouri, and director of retinal services at Pupils Vision Institute in Chesterfield, Missouri. She received her medical degree from the Johns Hopkins University School of Medicine in Baltimore, Maryland. Dr. Holekamp is on the editorial board of American Journal of Ophthalmology and currently serves as a reviewer for several ophthalmology journals, such as Archives of Ophthalmology, and Retina. Second presenter today is Associate Professor Andrew Chang. He is a visual retinal surgeon and ophthalmologist. He holds an academic appointment of Clinical Associate Professor at the University of Sydney. He is a consultant ophthalmologist and the head of ophthalmology and the head of retinal unit at the Sydney Eye Hospital. He is a medical director of Sydney Retina Clinic. He graduated from the University of Sydney. His commitment to international ophthalmology includes Secretary General of the Asia Pacific Vitreoretinal Society and council member of the Asia Pacific Academy of Ophthalmology. The third presenter today is Associate Professor Gerald Liew. He is a medical retina and subspecialist. He is an associate professor with the Westmead Clinical School, University of Sydney, and member of the Association for Research in Vision and Ophthalmology, American Academy of Ophthalmologists, and European Society of Retinal Specialists. So I'm going to go through the agenda. The first presentation is about understanding the disease. So we see how the AMD progress from the pathogenesis, and we understand the rationale for the treatment of this condition. The second presentation is about the tolerating fluid in AMD, and this will be discussed in a case-based basis. And then we have the flexible, individualized patient care in AMD, reaching the potential of aflibercept treat and extend. And the last presentation is about PCV, which is a very hot topic in Vietnam too. Achieving patient benefits from trials to the real world with aflibercept treat and extend. So I think that's a lot to cover. And I think there are a lot of interesting points that we'll see in those presentations. So what presentation is interested in you the most? It's more interesting in your opinion, Dr. Kevin Wong.
I think they're all really important. Pathogenesis have changed the way we think about PCV recently. PCV used to be a separate entity. Now it's actually classed as a variable AMD variable in the sense that it's a different spectrum of wet AMD. So for me, this new pathogenesis or understanding the pathogenesis of PCV and how it is included in wet AMD is extremely important. Also, for me, the individualized treatment is particularly of note for our daily clinical practice and how we are able to manage patients daily effectively to ensure best visual outcomes, to ensure that they have a good quality of life.
So in your clinic, what is the most used anti-VEGF therapy at your clinic at this moment?
At this point in time, for myself, I would be inclined to use aflibercept. I do use Avastin as well as Lucentis, but the most used for me at the moment is aflibercept.
So do you when you recommend the aflibercept for the patient, what is the most important point that you point out for the patient? What are the benefits?
Normally, in the beginning, I would discuss all three injections with the patient, namely Avastin, let's use brand names here, Avastin, Lucentis, and Eylea, giving them the individualized cost of each of these injections. And then I would discuss with them the individual benefits with relation to their condition. For example, in PCV, we already know that aflibercept monotherapy is not only clinically effective, it's as good as using combination PDT with Lucentis in randomized controlled trial. So for those type of patients, I would recommend them to try Eylea first or aflibercept first rather than Avastin. However, bearing in mind that I'm practicing in Vietnam, cost is a really big and major issue to Vietnamese patients. Therefore, if cost is an issue, they can start with Avastin first. It is equally reasonable as well as effective. And I will also have to discuss with them, as you mentioned earlier on, the burden of care. I need to tell them that treatments will be continued. It cannot be interrupted in order to maximize final visual outcomes. If they are to be interrupted, it must be interrupted within accepted parameters. And as well as finally letting them make the very important decision of what is best suited for their needs. Vietnam is a very big country. Certain patients have to travel a few days to come and see me. Some patients have to travel 6 to 8 hours to come and see me. Some patients even have to book into a hotel to stay overnight in order to get their treatment the following day, because we've arranged it for them to have treatments early as well as follow-up. So for me, the main considering factor first is the most effective medication for their condition, and then individualizing that treatment to suit their personal and familial needs.
Thank you very much, Dr. Kevin Wong. Let's go ahead to the webinar. I will see you after the webinar.
Sure.
Thank you.
Thank you.
Quý vị chờ đợi một chút để chuyển tiếp cái chương trình từ vùng sang. Trong cái chủ đề ngày hôm nay thì chúng ta sẽ bàn rất là nhiều sẽ có rất là nhiều thông tin về không những là về cơ chế bệnh sinh mà còn về những cái thuốc mới và cái vai trò của thuốc mới đó đối với cái trị liệu của mình hiện nay như thế nào. Liệu các thuốc mới đó có thay đổi được hoàn toàn cái trị liệu, cái phương pháp điều trị của mình bây giờ hay không? Bây giờ chúng ta đã kết nối được rồi. Xin mời quý vị.
These are our speakers. We have Nancy Holekamp from PPO's Vision Institute in the United States. And the second speaker will be Gerald Liew from Sydney, Australia. Here you can see the agenda for the night. I'll be speaking firstly on the pathogenesis of the disease treatment. And secondly, Nancy Holekamp will be discussing tolerating fluid in nAMD, and this is a case-based discussion. She will then move to cover flexible individualized patient care in nAMD and how we might reach the potential of aflibercept treat and extend. Gerald will focus on PCV and in particular will discuss with us real-world evidence with treat and extend. And finally, a highlight, we will have the audience Q&A. Let me begin with my talk. It is understanding the disease from pathogenesis to treatment. VEGF receptor 1 is expressed in multiple cell types within the choroid and the retina. This receptor 1 is one of 3 known VEGF receptors, and its ligands are VEGF-A, B, and placental growth factor. Expression of VEGF receptor 1 and its associated ligands is particularly affected by the oxygen concentration and inflammation. When there is excessive VEGF receptor 1 activation, we see this as a role in exudative retinal and choroidal diseases. And as you can see here, we have inflammation, fluid leakage, and vascular permeability, as well as neovascularization. And at the macula, this is manifested by edema. Aflibercept incorporates domains from 2 VEGF receptors for tight binding of both VEGF and placental growth factor. We can see here that aflibercept is specifically designed to form a tight inert 1-to-1 complex with each ligand, which has been described as a nearly irreversible two-fisted grasp. Aflibercept is the only globally approved anti-VEGF agent that blocks all VEGF receptor 1 ligands and the key VEGF receptor 2 ligand. Aflibercept also decreases placental growth factor. We see this in the aqueous humor of patients with retinal and choroidal diseases. We know that in such diseases such as diabetic macular edema and neovascular age-related macular degeneration, that placental growth factor and VEGF receptor 1 are upregulated. We can see here on the graph that in DME, levels of placental growth factor in aqueous humor are significantly reduced with aflibercept treatment. So the roles of VEGF and placental growth factor are now well established. But what about other molecules and pathways which are now of interest? We can see here that angiogenesis is complex and several signaling pathways contribute to it. The Tie2 Ang2 pathway is a target for intervention that has been recently explored in several clinical trials. So talking about Ang2, how relevant is it in targeting Ang2 when we manage retinal diseases? We know that under pathological condition, Ang2 expression is increased by VEGF stimulation of endothelial cells. So in theory, in high VEGF states, Ang2 may be relevant in retinopathy. That is when VEGF levels are elevated. However, under pathological conditions, low VEGF levels can be effectively achieved by suppressing VEGF itself with anti-VEGF monotherapy. And in this state, Ang2 serves as a weak agonist of the Tie2 receptor. Therefore, in these low VEGF states, when we have already suppressed VEGF with an anti-VEGF monotherapy, Ang2 may have limited relevance. So VEGF is a pivotal mediator of pathology in retinal disease. We know it increases vascular permeability and neovascularization, resulting in macular edema. And if we block VEGF, we can reduce the incidence of these events. Let's talk about some Ang2 binding agents that have already been clinically evaluated and how they relate to the native Tie2 receptor. We can see here two drugs that have been clinically evaluated. There's Vascumab on the left side and Faricimab. If we look here at the binding affinity, we can see that Vascumab is potentially a more powerful Ang2 inhibitor than Faricimab. And Faricimab on the right side has a weaker binding affinity to Ang2 than even the native Tie2 receptor. Therefore, competitive Ang2 binding may favour the Tie2 receptor over Faricimab. I'm going to share with you a study that many of you may not be familiar with. It's called the Onyx study. It is a phase 2 study which assessed the efficacy of nirseveskumab in combination with aflibercept head-to-head with aflibercept monotherapy over 36 weeks. We can see here that there was a low-dose combination of the two and a high-dose combination, and this was tested against monotherapy intravitreal aflibercept. And these are the overall results. We can see here that in all arms, there is an improvement in BCVA over the 36 weeks. And similarly, in all arms, there was a reduction in mean central retinal thickness from baseline to week 36. And all the curves are roughly similar. So in summary, there was no real difference between combination therapy with the Ang2 inhibitor nirseveskumab plus aflibercept versus aflibercept monotherapy alone. So we're in the clinic and we have a patient in front of us with neovascular macular degeneration, and we're choosing a drug. What molecular factors do we consider when selecting an agent in the clinic? Do we look at binding affinity? Is half-life important? Or are the binding targets important as well? For binding affinity, aflibercept has a greater binding affinity for VEGF-A compared to the other anti-VEGF agents, that is brolucizumab, ranibizumab, bevacizumab, and also faricimab. If we focus on half-life, we can see here that aflibercept's longer half-life potentially can result in increased duration of activity compared with other anti-VEGF agents who have a reduced or lower half-life. Aflibercept also has a wider range of binding targets compared with other anti-VEGF agents. We can see here that aflibercept targets VEGF-A, B, and placental growth factor, brolucizumab, VEGF-A, across to ranibizumab, blocking VEGF-A, the same for bezacizumab, and faricimab blocks VEGF-A and also the Ang2. So in summary, if we consider binding targets, aflibercept is the only globally approved anti-VEGF agent that blocks all VEGF receptor 1 ligands, VEGF receptor 2 ligand, and placental growth factor. And we have seen tonight that inhibition of Ang2 with nirseveskumab and aflibercept combination therapy did not give any additional clinical benefit compared to aflibercept monotherapy alone. If we consider binding affinity, aflibercept has a greater binding affinity for VEGF-A compared to other anti-VEGF agents. And half-life. Aflibercept's longer half-life may potentially result in increased duration of action compared to other anti-VEGF agents. Thank you. While Nancy is taking over control of the slides, I'd like to introduce Nancy again. Nancy has been a trailblazer in retina. Nancy, when you were working on oxygenation of the posterior segment, I read much of your work in the laboratory. And it's a real privilege to have her talk to us today, giving two wonderful talks, the first being tolerating fluid in neovascular AMD. And she'll share some cases with us to guide us on how we should manage this. Thank you, Nancy.
Thank you, Andrew, for that lovely introduction. It is my pleasure to be here to present some cases that help us discuss and understand fluid in wet macular degeneration. These are my financial disclosures. So I'm going to begin with a case, and this is an 84-year-old patient of mine with AMD. And at the time that I see her, she has dry AMD in the left eye, and you see the pigment alterations in the macula. And her vision at this time is 20/20. And so for a patient like this, I generally monitor them about every 6 months. So this patient returns 6 months later, and she is completely asymptomatic, but appears to have subretinal fluid. And so I diagnosed new onset wet AMD. And so the question is, being asymptomatic, a small amount of subretinal fluid, what would you do? And in general, I get a fluorescein angiogram when I diagnose wet AMD for the first time. And it may be the only time that I get an angiogram, but I do like to get an angiogram at baseline to make sure I'm not fooled or missing anything. And so I have a basis for comparison if I ever need to repeat the angiogram again during the course of treatment. And once I confirm that it is exudative wet AMD, I begin anti-VEGF therapy with monthly loading doses. And I generally begin with aflibercept, and I do strongly believe in loading doses. I call this the initiation phase of treatment, and I am trying to get the patient's disease under control. And in the initiation phase, I am trying to get the patient dry. In this particular case, I never get the patient dry. There's always a bit of subretinal fluid. And this is not a treatment failure. This is someone who may have an anti-VEGF intensive need. But as we will see, I still managed to extend the patient out, decreasing the treatment burden based on evidence from the ARIES clinical trial that we're going to talk about later today. And so she's doing well with Q12-week intervals, and her vision remains 20/20. And at every 12-week interval, she has this amount of fluid, which is less than 50 microns thick. But now I start to see a little bit more fluid 13 months later. And the question is, what would you do? And so we have some options. And one is that I could switch anti-VEGF agents. But as we'll discuss later today in the program, I'm not really a switcher. And so sometimes the best alternative is to alter the treatment interval. And so in this case, I decide to intensify the injection interval to Q8 weeks to get the disease just a little bit more under control. And with the intensification of the treatment interval, the lesion does respond, but I now have less subretinal fluid at each treatment interval, and visual acuity is still 20/20. So I use this case to help us understand the fluid compartments, because this patient had subretinal fluid, was doing quite well, and as the treating physician, I was comfortable controlling the disease while tolerating subretinal fluid. But the fluid compartment really does matter. If we look at intraretinal fluid, those cystic intraretinal spaces in the very fabric of the retina, we know that that is damaging to vision, and in fact is typically associated with worse vision, whether it's at baseline or through the course of treatment. On the other hand, subretinal fluid, that is fluid that lies completely under the photoreceptors and above the RPE, well, it's typically associated with better visual acuity compared to intraretinal fluid. And just a final note about the role of sub-RPE fluid. It's really unclear, and we don't have enough evidence from either prospective or retrospective post-hoc analyses in order to comment. And I won't really be talking about sub-RPE fluid in this presentation. So we're now going to review the evidence that suggests that intraretinal fluid is suggested with worse visual acuity, whereas subretinal fluid may be associated not only with good visual acuity, but oftentimes better visual acuity. So here we have a post hoc analysis of the CAT trial through 5 years. And on the left-hand side of the slide, we're looking at intraretinal fluid as determined by a reading center, whereas there's no intraretinal fluid, some non-foveal intraretinal fluid, or foveal intraretinal fluid. And in the presence of either non-foveal or foveal intraretinal fluid, you can see that the visual acuity outcomes are worse through baseline, year 1, year 2, and year 5. In contrast, when we look on the right-hand side of this slide, and we look at subretinal fluid again, in the presence of non-foveal or foveal subretinal fluid, the visual acuity outcomes in ETDRS letters is actually better over baseline year 1, year 2, and year 5 compared to eyes with no subretinal fluid. And this is really quite provocative and quite surprising. And post hoc analyses are generally hypothesis generating. And yet we see it again. And we see it when we look at the VIEW clinical trials through year 1. In the presence of non-foveal or foveal intraretinal fluid, visual acuity outcomes were worse. But in the presence of either non-foveal or foveal persistent subretinal fluid, the visual acuity outcomes were actually better at each time point investigated. So that is quite interesting. And now we're going to focus really just on subretinal fluid. And we're going to examine evidence that suggests that stable, residual subretinal fluid, as we saw in my patient, can be tolerated without having a negative impact on vision. And for this, we're going to turn to a Harbor post hoc analysis. And this is actually work that I was involved in that was recently published in the American Journal of Ophthalmology. And what we see here is the gray bars have eyes with subretinal fluid only. And you can see that it's a substantial number of eyes. It's 122 eyes that, despite monthly or PRN treatments with anti-VEGF therapy over 1 and 2 years, some of these eyes have persistent subretinal fluid, and they're not treatment failures. They still see well. And in fact, the eyes with persistent or residual subretinal fluid only had the best visual acuity outcomes compared to eyes that were completely dry, eyes with both subretinal and intraretinal fluid, or eyes with intraretinal fluid. When we look at having residual versus resolved fluid, on the left-hand side, we can see that having residual intraretinal fluid is damaging to vision, and that the mean change in vision was about minus 3.5 or minus 3.4 letters, which was statistically significantly different. But on the right-hand side of the slide, when we look at having residual subretinal fluid versus resolved subretinal fluid, the visual acuity outcomes were actually better in the eyes with residual subretinal fluid. And that difference was also statistically significantly different. So the data highlight that residual subretinal fluid was associated with better visual acuity compared with resolved subretinal fluid, and that residual intraretinal fluid was associated with worse visual acuity compared with resolved intraretinal fluid. And this next slide here is one of my favorite analyses of the Harbor clinical trial data. This was done by Marco Zarbin and colleagues and recently published last year. And what it's telling us is that there's no amount of subretinal fluid that was found to be damaging to vision. In the far left-hand bar, the gray bar, we have eyes that are dry. And yet on the right-hand side, we have different amounts of residual subretinal fluid between 0 and 50 microns, between 50 and 100 microns, and even greater than 100 microns of subretinal fluid. And no amount of persistent subretinal fluid was damaging to vision. But remember, these eyes are still getting treated in the Harbor clinical trial. So the disease is being controlled, but in some eyes, we can't completely eradicate the activity of the CNV. So these data highlight that residual subretinal fluid may be associated with better visual acuity outcomes compared with the absence of subretinal fluid. So you may all be familiar with the fluid study in Australia. This is one of my favorite studies in all of ophthalmology, where it was a treat and extend protocol using ranibizumab that tolerated up to 200 microns of subretinal fluid. And in one arm of the study, there was an intensively treated group whose goal was to eradicate all fluid, intraretinal fluid and subretinal fluid. But there was a relaxed arm that had the goal of eradicating all intraretinal fluid, but it would tolerate up to 200 microns of subretinal fluid. And we see the primary endpoint at month 24. And we see that the intensively treated group and the relaxed group were both non-inferior at the 24-month primary endpoint. And you may think that if you're being relaxed and that you're tolerating subretinal fluid, you might be preventing eyes from having the best visual acuity outcomes. But we see that both arms of the study achieved a vision gain of greater than or equal to 15 ETDRS letters at the same rates. And so there's a very important take-home message here, and it's one of the most important take-home messages of today's presentation, and that is aggressively treating persistent residual subretinal fluid does not appear to provide additional vision, suggesting that a zero tolerance approach to residual subretinal fluid is not needed. Now, there are other ways to look at this data, and there's something called an SLR, a systematic literature review. And it also supports the notion of differential impacts of fluid compartments on vision. And when 27 prospective observational and post hoc studies were examined, it was again found that persistent or new intraretinal fluid had a negative impact on vision. But most studies suggested that subretinal fluid at baseline or stable subretinal fluid throughout year 1 of treatment did not negatively affect vision, as we saw in my patient. And the impact of fluid compartments on vision actually was the same, regardless of anti-VEGF agent used. So there was a key conclusion from the systematic literature review that current evidence suggests that after an initial treatment course, anti-VEGF regimens that do not tolerate intraretinal fluid, but tolerate stable, persistent subretinal fluid while still being treated, can achieve their best visual acuity while minimizing the treatment burden. And it's about finding the balance of maximizing vision and minimizing the treatment burden. So we're going to spend some time talking about aflibercept treat and extend regimens with what I call a pragmatic retreatment criteria. And this pragmatic approach can reduce the treatment burden while maintaining vision gains. And we see this with the ARIES clinical trial. It's one of my favorite studies because it allowed extending the treatment interval as long as there was less than or equal to 50 microns of stable subretinal fluid. And it showed that you could achieve meaningful visual acuity outcomes with up to Q16-week treatment intervals. And here we see meaningful visual acuity gains at week 104 in both arms of the study of plus of plus 4.3 and plus 7.9 letters. But we also see extended treatment intervals where 49.5% of patients, that's almost 50% of patients being dosed at Q12 weeks or longer, and 28.6% of patients, almost 30% of patients being dosed at Q16 weeks. But we have another clinical trial that uses proactive treat and extend while allowing some residual fluid. It's the Altair clinical trial. And you could have extension as long as there was no increase in central retinal thickness of greater than or equal to 100 microns. But you could also maintain the treatment interval as long as there was no increase in central retinal thickness of greater than or equal to 100 microns. And what we see again is meaningful visual acuity gains in ETDRS letters at week 96. And we see extended treatment intervals. Here, almost 60% of patients being dosed at Q12 weeks or longer, with almost 44% of patients being dosed at Q16 weeks. And so a pragmatic approach really allows us to maintain vision improvements while extending that treatment interval. So back to my patient. And one of the things you may notice is that I have long-term follow-up of this patient. We are now more than 2 years into her management. And with 12 months of additional follow-up, despite continued Q8-week anti-VEGF injections, the subretinal fluid persists and even worsens. And yet she has good visual acuity. She's asymptomatic. She's reading and driving very well. And so the key question arises, can we tolerate this fluid? And would we contract the interval to 4 weeks? But the patients don't want this. The patients actually are quite satisfied to come every 8 weeks and hope for that extended dosing interval. And in fact, the patient was kept on Q8-week dosing intervals because the fluid here is subretinal fluid with no appearance of intraretinal fluid. And I believe that her disease is being controlled with an individualized dosing interval of Q8 weeks. So I have a second study, again, with long-term follow-up. And this patient is 74 years old with wet macular degeneration and has already been treated for 2 years with anti-VEGF injections given every 12 weeks in the right eye. We see her vision is 20/40. We see stable subretinal fluid that measures less than 50 microns in thickness. And the left eye is dry. So the vision in the right eye is 20/40. The vision in the left eye is 20/25. And I'm seeing her about every 12 weeks until she comes in 8 weeks after the injection in the right eye because she now has symptoms in the left eye. I just want to point out that even at 8 weeks, when the retina is dry, vision is still 20/40. And I could choose to treat her at a Q8-week interval with a dry retina, but I can also extend her out to Q12 weeks, allow a bit of subretinal fluid, and the vision is still 20/40. But here we are with new onset wet macular degeneration. It's intraretinal fluid in the left eye, and I begin monthly loading doses. And 13 months later, I'm very pleased because I've gotten her to every 12 weeks in both eyes. Vision is back to baseline at 20/40 in the right eye, 20/25 in the left eye. And lo and behold, at this 12-week interval now in the right eye, there's no fluid. Again, these patients have to be monitored because their disease can change. And we can make treatment adjustments based on how they change, and we can individualize the treatment approach. But here I'm quite satisfied that I have both eyes on a Q12-week interval. So 3 months later, she develops new intraretinal fluid with hemorrhage. And you see hemorrhage in the near infrared photograph on the left-hand side. It's just in the inferotemporal macula. Well, I don't like intraretinal fluid and I don't like hemorrhage. Intraretinal fluid is damaging to vision, and we see the vision is now 20/60. So here I would recommend contracting the interval all the way back down to Q4-week intervals. And I give her consistent Q4-week intervals for 3 months. At the bottom, you see that despite this intensive treatment, vision is now 20/70. It's actually fallen a bit, even though the hemorrhage has resolved, and I still have persistent intraretinal fluid. So I continue. And eventually 10 months later, I am able to eradicate the intraretinal fluid and begin extending the treatment interval. And so we're back to Q12-week anti-VEGF intervals for both eyes. So this is long-term follow-up on a woman whose disease changes, and I'm managing both eyes. And so you have to be open to individualizing the therapy. And it's possible to tolerate subretinal fluid, but a take-home message is not to tolerate intraretinal fluid and to intensify the treatment interval. I have one final case. This is a 66-year-old man with wet macular degeneration who has good vision in both eyes, but complains of new distortion in the right eye. And importantly, he lives very far away from my office and has to drive himself to the office. So I get a fluorescein angiogram, and in the right eye, there's some perhaps late stippled hyperfluorescence in the infratemporal macula just off the foveal center, again in the right eye. The left eye looks fine, but it's really the OCT that shows me subretinal fluid. And even though he's 20/20, with this appearance, I initiate monthly loading doses with aflibercept because I believe in initiation with loading doses. And despite this therapy, when the patient comes back after 3 loading doses, there's still some persistent subretinal fluid. This is not a treatment failure. This is someone who I'm controlling the disease. The vision's 20/20. And in fact, he says his distortion is better. And he begins telling me that he can't come to the office every month. And based on the ARIES clinical trial, with stable subretinal fluid, I actually extend him to a Q8-week dosing interval for the next 12 months. And I do have controlled, stable subretinal fluid. And he tends to look like this at every 8-week dosing interval. I finally get him out to Q12-week dosing. He receives 3 doses at that Q12-week interval, but then he shows up with hemorrhage in the left macula. And the question is, well, what do you do next? So I confirm wet macular degeneration in the left eye with a fluorescein angiogram. And again, I believe in loading doses. And I tell this patient that because of new wet macular degeneration in the left eye, he must now come every 4 weeks for his 3 initial loading doses. But he doesn't want to be treated in both eyes because he's driving himself. So it gives me an opportunity actually to monitor that right eye, the eye that's had subretinal fluid. And 4 weeks post-injection in the right eye, we see at the top frame here on the right that he still has a sliver of subretinal fluid. Again, this is not a treatment failure. This is a patient whose disease is being controlled. He has excellent vision, and I can tolerate a bit of subretinal fluid. He comes in again, 8 weeks. I can't give this eye a shot. I'm treating the fellow eye, and I see a slight increase in the subretinal fluid, but vision is stable. Now I see him at 12 weeks post-injection. There is a slight increase in subretinal fluid. Vision is good. And then the bottom frame on the right shows the appearance at Q16 weeks post-injection. Here I do have the opportunity to treat him, and I now place this right eye on Q16-week dosing because the vision is stable and I feel like the disease is under control, and I can extend this eye out to Q16-week dose, as we see with a very pragmatic approach based on both the ARIES and ALTAIR clinical trials. So in summary, evidence suggests that stable subretinal fluid can be tolerated and is associated with sometimes even better visual acuity outcomes compared with the presence of intraretinal fluid, which we know is damaging, or a dry retina. The fluid study, a prospective treat and extend study, suggests that aggressively treating persistent residual subretinal fluid does not provide additional vision benefits, indicating that a zero tolerance approach to subretinal fluid is not needed. And in fact, you saw that in the cases that I presented today. And then finally, the Altair and Aries clinical trials are proactive aflibercept treat and extend studies, and they achieved clinically meaningful vision gains with extension of the treatment intervals up to Q16 weeks in the presence of some sub-residual fluid, as we saw in my last case. And so I think that these clinical trials, the fluid study, Altair and Aries, and even the post-hoc studies that we saw are very helpful in guiding us in the management of patients, where we try to maximize visual acuity gains while minimizing the treatment burden. And with that, Andrew, I'll say thank you, and I'll pass it back to you.
Thank you very much, Nancy. You've given us a lot to think about. That is, we should be really concentrating on control. And after all, that is really the endpoint, isn't it? It's vision. And what you've shown us is that if vision can be maintained, then we can tolerate stable residual fluid.
Well, yes.
Thank you. I think we'll move on. Yes.
One quick comment, you know, for the 15 years of the anti-VEGF era, we've been taught to treat to dry, and we've never proven that dry is better. What we've shown is that treatment is better and control of disease is better. And I think we're beginning to understand that better through many of these clinical trials.
I agree, Nancy. The paradigm is shifting now as we become much more nuanced in what we need to aim for in each individual patient. We'll move on to your next talk, which is also very stimulating, and that is how we can adjust what we do to get the maximum potential from aflibercept in a treat and extend protocol. Thank you, Nancy.
Well, thank you, Andrew. And I'll jump in with the next presentation, which is really about flexible, individualized management of our patients with wet AMD and reaching the full potential of an aflibercept treat and extend regimen. So treat and extend really has become the gold standard for treating our patients with wet AMD. And in fact, it's the preferred treatment regimen around the world. And it continues to evolve as we gather new evidence. But the rationale, the physiologic basis for treat and extend and an individualized treatment approach is seen here with this study published out of a lab of Sasha Fauser in 2016. And what we see is 7 patients where they tap the anterior chamber to gather aqueous humor, and they calculated the mean duration of VEGF-A suppression. And the first take-home message from these 7 patients is that the mean duration of VEGF suppression is different in all 7 patients. And the second take-home message from this slide is that the mean duration of aflibercept averaged over these 7 patients was 67 days or longer than the mean duration of VEGF suppression for ranibizumab at 34 days. And so this really speaks to treatment individualization for our patients with wet AMD. Now, what we've also learned over the last 15 years of the anti-VEGF era is that patient treatment follows a biphasic distribution, where we see a peak of some individuals that require intensive anti-VEGF treatment intervals, and others have less frequent treatment needs. And we see here the peak at about 8 weeks and 16 weeks. And we see that across multiple clinical trials. Here, for example, in the Lucas clinical trial, it was treat and extend with ranibizumab and bevacizumab. We see that biphasic distribution. We see a peak at 4 weeks where some eyes require intensive treatment intervals. And we also see another peak at about 12 weeks. So with ranibizumab and bevacizumab, the peaks were at 4 weeks and 12 weeks. But in contrast, in the Aries clinical trial, we see this biphasic distribution. But now the peaks are at 8 weeks and 16 weeks, again, speaking to longer mean VEGF suppression with aflibercept compared to other anti-VEGF agents. Now, we're going to contrast traditional treat and extend regimens, which we will then compare with what I call pragmatic treat and extend regimens. So in the traditional model, where we treated to dry and only extended if the patient were completely dry, we have examples of that with the Lucas, the Trend, the Rival, the Fluid, and the Can Treat studies, the exception being the Fluid study that did tolerate some fluid. But in the others, they were often treated to dry. And we see that it really created a high injection burden. And when we look at the ability to extend out to 12-week intervals, we see that basically we could get out to 33% to perhaps 43% of eyes getting out to that Q 12-week interval, again, with a traditional treat and extend regimen. But now when we think about a pragmatic treat and extend approach that really addresses patients' individual treatment needs with aflibercept, we're going to look at extending out to Q 16 weeks and really having flexibility to treat our patients anywhere from Q 4 weeks to Q 16 weeks. We're going to take a closer look at the Altair and Aries clinical trials. They're really the first studies that looked at up to Q 16-week treatment intervals. So they're both fairly large studies with over 240 patients, and they received loading doses of aflibercept injections at baseline, week 4, 8, and week 16. Then at week 16, they were randomized, at least in Altair, was randomized to 2-week adjustment or 4-week adjustment, treat and extend adjustment intervals. In Aries, there was early start, treat and extend versus late start, treat and extend after a full year of fixed dosing. Now, importantly, in this pragmatic retreatment criteria, both studies tolerated fluid. Altair was measured in central retinal thickness of greater than or equal to 100 microns. Aries came a little bit later, and it was a greater than subretinal fluid of 50 microns in thickness. That was the criteria for shortening the treatment interval, but it could be extended if there was less than or equal to 50 microns of subretinal fluid, showing an evolved, more nuanced approach to tolerating fluid. So in the Altair clinical trial, we saw meaningful visual acuity gains, as I mentioned earlier, at week 96, that included improvements of plus 7.6 and plus 6.1 letters on the ETDRS eye chart. We also saw that regardless of whether it was 2-week or 4-week treatment intervals, over 96 weeks, on average, 10.4 injections were given. But up to 44% of patients could be dosed at a Q 16-week treatment interval. And that was very similar despite 2-week and 4-week treatment adjustments. Now, importantly, once you reach that Q 16-week interval, what was the chance that you could actually still be at that Q 16-week interval through week 96? And overall, it was 85.8%. But if you look down at the bottom, in yellow at the 2-week adjustment interval patients, if you were adjusting by 2-week intervals and you got to Q 16 weeks, 96.2% of patients maintained that Q16-week interval. And so there may be a slight advantage to 2-week interval adjustments, knowing that once you get to Q16 weeks, you have a very high chance, greater than 95% chance of maintaining it through week 96. So in the ARIES clinical trial, again, it tolerated subretinal fluid. We see again, very meaningful visual acuity gains through week 104. And despite early start or late start treat and extend, through week 104, we're giving 12 or 13 injections. So while we're tolerating fluid, we are not under treating. That's key. And we see a biphasic, bimodal distribution again that's shifted out to the right, where 28.6% of patients were treated at Q16 weeks, but also at Q8 weeks. So again, we see that biphasic, bimodal distribution. But I do want to spend some time talking about the 6.6% of patients that by week 104 were being treated at an interval of less than 8 weeks. At some point during the study, this was 23% of patients required what we would call a treatment intensive interval. But over the course of the study, that was 23% of patients, but by the end of the study, only 6.6% of patients still required that intensive treatment. The majority were allowed to be extended. So what we're going to talk about is this group of patients that may have an initially high treatment need, and that these patients actually should be treated intensively. As we saw with one of my patients, where I shortened the interval to Q4 weeks for a period of time, but I was then able to extend out to Q16 weeks. So what we see here is the yellow bars are these injection intensive patients. They are not treatment failures. When we look at mean BCVA, they're doing as well as the patients that are non-injection intensive. They just have a higher VEGF need and need for a short period of time, at least a higher injection need. So again, this highlights the importance of an individualized treat and extend approach for all patients, some who may have a need for more frequent injections at some point during their treatment course. But again, as we learned in the ARIES clinical trial, where injection intensive patients received 1 or more less than Q8 week treatments at any point after those 3 initial monthly loading doses, well, that was 23% of patients, 14% in year 1, 9% in year 2. But we saw that many of these patients could then be extended out to Q16 weeks, and that these intensive treatment intervals were mostly transient. A very important point. So when you reach the patients, when you're treating them, and they may have persistent intraretinal fluid or persistent subretinal fluid, or they may not quite have the visual acuity gains that you're hoping for, or they may be requiring a treatment interval of less than or equal to 8 weeks, you may be thinking about switching. And what we learned from the ARIES clinical trial is that about 46% of patients actually had what we call hypothetical switch criteria, where you may think they're a treatment failure, you may think about switching. And when we look at the ARIES clinical trial database, and these eyes were not switched in the ARIES clinical trial, we see that their visual acuity outcomes were every bit as good with the people who did not meet criteria, the hypothetical switching criteria. So on the left-hand side, we see these patients with persistent intraretinal and/or subretinal fluid. And what we see here is that after week 24, the visual acuity outcomes were actually no different than the patients who did not meet these hypothetical switch criteria. On the right-hand slide, we've now combined fluid with patients where you may be unhappy with their visual acuity outcomes, but they were not switched. And after 6 months, from week 24 to week 104, they did as well as patients who did not meet the hypothetical switch criteria. So the take-home message is at the bottom. BCVA outcomes were not worse in the hypothetical switchers, irrespective of hypothetical switch criteria, demonstrating little rationale for early switching from a continued prospect aflibercept treat and extend regimen. And quite frankly, as I mentioned earlier, I'm not a switcher. What I think these patients need is continued therapy and control of their disease. So we've talked about clinical trial data, and we're going to just briefly look at some outcomes in real world patients, because we know that sometimes clinical trial data does not translate to real world patients. But here we see from this paper out of Finland, published in 2020, that up to 67% of patients on aflibercept treat and extend could achieve greater than or equal to 12-week intervals. And we see that that number is 46% to 67% of patients in the real world. And again, on the left-hand side, we see meaningful visual acuity gains. Here we have real-world studies with 4 years of follow-up out of Switzerland and then more fields in England. And again, we see around 50% of patients in both of these real-world studies achieving Q 12-week or longer treatment intervals with meaningful vision gains through 4 years of studies. Here we have systematic review and a meta-analysis looking at a huge number of eyes, over 100,000 eyes, 81 randomized clinical trials, 95 prospective cohort studies, and 100 retrospective cohort studies. And again, we see superior vision gains with aflibercept versus ranibizumab across all studies. And we see the same trend observed if we only look at real world or observational studies. And finally, fixed or treat and extend regimens were more favorable with aflibercept over PRN treatment regimens. And just a final word about safety, because safety of our patients is actually a top priority. And we learned this through the brolucizumab experience, where post-marketing reports showed an incidence of retinal vasculitis, retinal vascular occlusion, and in fact, vision loss for a total of all 3 events of interest that approximated 5 patients per 10,000 injections. And in fact, Novartis halted the Merlin trial that looked at Q 4-week dosing. And now Novartis does not recommend less than Q 8-week dosing of brolucizumab. And as we saw, some patients actually still require these intensive injection intervals. When we look at the same post-marketing database for aflibercept, but it's now more than 50 million doses sold worldwide, more than 7 million patient years of experience, we see a very, very small percentage of vision loss for the total of these 3 events of interest. It's almost unheard of. It's at 0.01 rate per 10,000 injections. And so across clinical trials and post-marketing reports, retinal vasculitis and artery occlusions have not been a safety concern for aflibercept. So in summary, I'd like to close with 3 important points. Number 1, a proactive, individualized aflibercept treat and extend regimen with what I'll call a pragmatic retreatment criteria that allows some subretinal fluid, can meet the needs of all patients with wet macular degeneration, and it can allow for flexible, individualized dosing intervals between Q4 weeks and Q16 weeks. Across clinical trials and now real-world practice, aflibercept treat and extend achieves meaningful long-term vision gains with a reduction in the treatment burden beyond year 1. We have long-term follow-up. And then finally, aflibercept has a well-established ocular and systemic safety profile. And we know that it is well tolerated in clinical practice now with a very large global experience. And with that, Andrew, I'll turn it back to you.
Thank you very much, Nancy. You've shown us that aflibercept, both in trials and in real-world evidence, is an effective drug that allows flexible dosing. And you've shown us with a pragmatic approach how we can reduce the burden to our patients with less frequent injections whilst controlling the disease. Our final speaker will be Gerald Liew. And this time he's going to be focusing on PCV, and in the Asia Pacific area, this is a very substantial manifestation of exudative maculopathy. So Gerald, please share us your experiences.
Thank you very much, Andrew. And it's a pleasure to be here and to speak after yourself, Andrew and Nancy. I'm going to talk about PCV, polypoidal choroidal vasculopathy, and how we can use clinical trial and real-world evidence to achieve excellent outcomes for our patients using an aflibercept treat and extend treatment regime. These are my financial disclosures. Now, the next few slides are going to go into how the emerging evidence suggests that patients with PCV can now be treated similarly to those with neovascular AMD using a proactive aflibercept monotherapy. So way back in 2016, the Everest-2 trial compared ranibizumab plus initial photodynamic therapy with ranibizumab monotherapy. This trial showed that vision gains with ranibizumab and verteporfin PDT was superior to those with ranibizumab monotherapy. Combination therapy required fewer injections over 2 months. However, there was a problem because access to PDT at baseline, it does pose several challenges, especially given the supply of Visidyne is becoming limited. And there are also concerns regarding overtreatment with initial and repeated use of PDT. Now, since that time, a number of other trials have come up with more evidence, which shows that PCV can be treated similarly to patients with neovascular AMD. For example, in the VIEW-2 trials, a sub-analysis of Japanese patients with PCV found that aflibercept monotherapy achieves comparable outcomes in patients with PCV and those with nAMD. And you can see that over here with the lines being very similar. The PLANET study also showed favorable long-term vision gains in patients treated with aflibercept monotherapy with PCV. This study in particular showed that PDT can in most cases be used as a reserve rescue therapy for patients who meet specific criteria. Now let's look into PLANET in further detail. PLANET was interesting because in the second year of treatment, patients could switch to an optional treat and extend dosing. This would help to reduce the treatment need. And what this showed was, once patients which were switched over to a treat and extend, vision gains remained stable. What's more, only half the number of injections were needed in the second year once you switch over to treat and extend. So this shows that treat and extend is a viable option for the treatment of PCV and achieves excellent long-term maintenance of visual acuity gains. Now, the next few slides are going to show how a proactive aflibercept treat and extend can achieve meaningful and sustained long-term vision gains in patients with PCV with outcomes that are comparable to those with nAMD. So back to the Altair study, which Nancy has covered very well. This is an interesting study which assessed the efficacy of aflibercept treat and extend using a 2 or 4 week treatment interval adjustment. let's focus on those patients from Altair who had PCV, which was a bit over 1/3, around 37% of patients. Let's see how they did compared to the other patients with neovascular AMD. Now, I'll just like to highlight again how Altair's treat and extend criteria is a very pragmatic or proactive way of treatment. Patients were allowed to have some residual fluid, provided it wasn't getting worse, and they could be maintained on that interval. So how did the PCV patients do? They did rather well. So on average, vision gains were achieved and maintained through week 96 in patients with and without PCV. What's more, around half the number of patients with PCV were able to be extended out to Q12 weeks by week 96. This is the same as, well, roughly the same as the neovascular AMD patients, showing again that both the PCV and neovascular AMD patients appear to respond similarly to an aflibercept treat and extend treatment regime. Now, moving on to some real-world studies, Maruko et al. Looked at 2-year outcomes of aflibercept treat and extend in PCV and neovascular AMD. This is an interesting study as well, where patients were extended by 4 weeks at each time. What did this patient find? What did this study find? Around half of the patients in this study had PCV. And this study found that the response to the treat and extend with aflibercept in patients with PCV was very similar to that in patients with neovascular AMD. And again, 67% of patients with PCV, more than the patients with neovascular AMD, were actually able to achieve 3-month treatment intervals by the 2nd year. Now, after this, I'm going to talk about how a personalized treat and extend with aflibercept can provide meaningful vision gains and extended treatment intervals for patients with PCV. Theo et al. Conducted a very innovative study, a randomized trial looking at aflibercept with a personalized treat and extend regime compared to a fixed Q8-week regime for patients with PCV. Let's look a bit more into this. So this study had 3 arms. One arm, after the loading dose, the normal loading dose of 3 aflibercept injections monthly, some patients were randomized to Q8-week injections. This is a fixed regime. Other patients were randomized into a personalized treat and extend protocol, where patients had the loading dose, and then after that, they were evaluated for the presence of polyps with ICGA. If there were no polyps present, treat and extend could commence. If there were polyps present, then patients went through another cycle of 3 monthly injections of aflibercept. This is very innovative because this individualized protocol provides an optimal treatment for all patients with PCV by detecting the active or recalcitrant polyps at the appropriate time and prolonging the intense initial treatment phase. It also allows those who did not need, those with a low treatment need, to extend intervals at an early stage because they did not require such intensive treatment. What did this study find? Vision gains in the personalized treat and extend arm were very similar, non-inferior to those in the fixed Q8-week arm. What's more, patients in the personalized treat and extend arm achieved greater reduction of central subfield macular thickness. Now, 69% of patients in the personalized treat and extend arm achieved greater than or equal to Q10-week treatment intervals by the end of 1 year. It is likely that if the study continued beyond 1 year, even more patients could be extended further to Q12 weeks, maybe even Q16 weeks. It's very hard to extend to maximal interval within just 1 year. Now, 55% of eyes in the personalized treat and extend arm experienced complete polypoidal lesion regression at the end of 1 year. So what this means is, in the personalized treat and extend arm, patients with persistent polyps at week 12, 1/3 of them achieved complete polypoidal regression, complete closure of the polyps by 6 months. In the fixed arm, none of the patients achieved complete closure of the polyps. Now, the next few slides are going to cover how clinical trial-like outcomes with aflibercept treat and extend can be achieved in real-world patient populations with PCV. These are the studies we talked about today, and all these studies have shown that a proactive treat and extend with aflibercept can achieve and maintain vision gains similar to patients with neovascular AMD in patients with PCV. Now, other studies in the real world have shown that similar results can also be achieved with aflibercept treat and extend. High vision gains can be achieved, and they can be maintained with long durability. All of these studies show that around half of patients can be extended out to Q12-week injection intervals. And in fact, some can even go out to Q16-week intervals, slightly less than half. Now, this is one of my patients, and let's go through what happened with this patient. This is a 68-year-old male who complained of distorted vision. His visual acuity was 6/12. And you can see how on the OCT he has multiple peaked pigment epithelial detachments with hyperreflective interiors. Now, in the interest of time, let's go straight to the diagnosis. When you see an appearance like this, it's highly suggestive of PCV. These hyperreflective areas within the PED, we speculate, are most likely the polyps themselves. This was confirmed on FFA as well as ICGA. You can see the nice polyps. Now, what did we do? So I started treatment with aflibercept monotherapy. Now, it's worthwhile thinking about other treatment options at this stage. Photodynamic therapy, yes, that is certainly one possibility. Thermal laser, given that these are peripapillary lesions and there is less risk of damaging the fovea, that's also another option. And it's certainly quite viable for people to consider that. In this case, though, I decided to choose aflibercept monotherapy. 1 month later, after a single aflibercept injection, the SRF has almost fully resolved and vision has improved to 6/7.5. Things are going well, so let's continue. After 3 loading doses, as Nancy has said, very important to load to get best outcomes, I could extend by 2 weeks. There was no subretinal fluid, no signs of activity. I kept extending, and after six aflibercept injections, you can see that the PEDs, the pigment epithelial detachments, and the polyps have started to regress in line with what was shown in the TEO randomized trial. After 8 injections out to 16-week intervals, most of the polyps, most of the PEDs have now regressed, just a little bit remaining here and here. At no time was there any regression, at no time was there any reactivation with new subretinal fluid. The patient continued to be extremely stable with Q16-week injections of aflibercept, and vision improved to 6/6. So this case study shows that aflibercept can regress pigment epithelial detachments in PCV, and sustained control can be achieved with Q16-week dosing intervals. You can see the OCT showing pre-treatment and post-treatment with excellent regression of the PEDs as well as all fluid. So in summary, a proactive, pragmatic aflibercept treat and extend regime can achieve meaningful long-term vision gains in patients with PCV, which are comparable to those with neovascular AMD. Across clinical trials, proactive aflibercept treat and extend achieves meaningful long-term vision gains in patients with PCV, and treatment intervals can be extended out to Q16 weeks quite safely and effectively. Finally, clinical trial-like outcomes with aflibercept treat and extend are reproducible in real-world patient populations with PCV, and with treatment intervals up to Q16 weeks, as we have seen. Okay, thank you very much for that. And I'll pass control back to you, Andrew.
Okay, thank you very much, Gerald. So we'll now have a question and answer session with Gerald and Nancy. We've already got some excellent questions which we'll cover, but before we get on to fluid, I wanted to ask Gerald a little more about polyp closure and PEDs. What do you aim to do when you treat? Do you aim to treat to flatten the PEDs and presumably you're closing the polyp, or what else are you aiming for, Gerald?
Thank you very much, Andrew. That's a very good question. I think the answer is evolving. I aim to control the disease. I don't think polyp closure is as high a priority these days now that we have treatment with anti-VEGF. The analogy is with neovascular macular degeneration. More and more evidence is accumulating that the two diseases are actually quite similar. For example, in neovascular macular degeneration, there is an underlying choroidal new vessel or macular new vessel, however we want to call it. And now we know that you cannot actually close that. We cannot eliminate or regress the new vessel completely, but we control the activity and we maintain good vision. I feel, and I think the evidence is beginning to point that way, that that's a similar approach that we should take with PCV. Closure of the polyp is a very nice goal, but probably not essential, as long as we can control the disease, control activity, control fluid, and maintain good vision.
Nancy, is that your approach also for PCV as well as neovascular AMD?
I agree with Gerald. I think that they're very, very similar, and that we need to think about controlling disease because we may not be able to affect complete closure of either the PCV polyp or the choroidal neovascularization in wet macular degeneration. So I think we need to think in terms of disease control with consistent therapies that are able to maximize vision but minimize the treatment burden.
We've got a very good questions for polyps. One question is, when do you routinely repeat the ICGA to look for regression of polyps? Gerald, would you like to answer that?
Sure, that's a very good question. These days, I tend not to routinely repeat the ICGA. I find it doesn't really change what I do. The polyp may be there, or the polyp may have closed, or the ICGA quality may not be sufficient to determine that. But in the end, I am treating the patient. If the patient is not responding as expected, for example, if the patient has been stable on a certain treatment interval, and then there's deterioration, perhaps there's, and in fact, this did happen in one patient, perhaps there's a new hemorrhage somewhere, then I would repeat the ICGA. And what I found in that one patient was, interestingly, the patient developed another polyp somewhere else, away from the initial lesion field. So in that situation, it was helpful. I'm not sure that if I did not have access to ICGA, I would have done things differently, because if there's new hemorrhage, you would automatically intensify treatment again. But it was useful to know.
Nancy, do you repeat ICGA once you've made an initial diagnosis?
Generally not. And in fact, I generally get them at baseline, and I repeat them if I'm not sure what's going on, if I have any question, if I feel the patient is not responding. And quite frankly, those instances are really quite rare because I think both wet AMD and the PCV variant of AMD, they respond well. So it's rare that I end up repeating either the ICG or the fluorescein.
There is another question, Nancy. The question is, would you share with us any criteria you have in stopping anti-VEGF therapy? And this question was actually directed at PCV, but you can answer it for AMD as well.
Well, it's a great question because we have large clinical trials that are very helpful in telling us when to initiate treatment and how to treat, but would we ever fully discontinue treatment? And if I have someone who has been on an extended interval for a long period of time, I could talk to them about trying to terminate treatment, but then it requires intensive monitoring. Because if I weren't going to give someone an injection, I would have to see them every month for a while. And so I've just traded an injection every 16 weeks for coming back for monitoring every month. And I can tell you that a lot of my patients preferred to be treated and not see me for 4 months. But if all I can say is if you were going to consider discontinuing treatment, never discontinue monitoring. And to make that jump, you would have to initiate frequent monitoring visits. And many patients would rather be treated, actually.
That's what I'm finding with my patients. Gerald, what's your perspective on that, both with PCV and neovascular AMD?
Sorry to interrupt you, Andrew. If you wanted to complete what you wanted to say first, I could follow up after that.
No, please go ahead, Gerald.
Okay. Well, I just wanted to echo what Nancy said. I mean, sadly, neovascular AMD and PCV, which is more and more like a sub-variant of it, is a lifelong condition, and you should continue. And in Australia, we have the long-term FRB, Fight Retinal Blindness Registry, I think, which showed that some patients who stopped treatment for whatever reason, we don't know why, most of them reactivated. I think half to 3/4 reactivated within a year or two. So it is a long-term treatment. I might just add the caveat that none of us lives forever, and sometimes patients do perhaps develop dementia, or they no longer need good vision. So in that situation, if the cost of attending treatment or the risk of injections begins to outweigh the benefits, maintaining good vision, maintaining reading vision, driving vision, then you could have that discussion to consider stopping treatment.
Good point, Gerald. And I might add too, at that point, often it's important to involve the carer, the children, and perhaps even the GP, so everyone's harmonized with that decision. Nancy, we've got other questions. A number of the audience are interested in how you define stable subretinal fluid. One question here is, can you express it in microns? Can you put a number on it? Can you just tell us a little bit more about what you would regard as stable subretinal fluid?
No, it's a great question. And quite frankly, I'm often surprised that when I see my patient back at their interval, whether it's 10 weeks or 12 weeks, their OCT looks exactly like it did before, as I showed in my cases. And with a OCT imaging, it will measure the thickness of fluid, and you can register the OCT images, so you can actually look at the same place at the same point in time. And I really like the ability to measure the thickness in microns, and I like to see if it's relatively the same. So although the ARIES study used less than 50 microns of subretinal fluid, and I believe 50 is a really good marker, and I'm comfortable with 50 or less in my own practice, There are other post hoc analyses that have looked at other levels of fluid, such as 75. So some people use 75 microns. And again, I showed that Harbor post hoc analysis done by Marco Zarbin et al. That showed there was no amount of subretinal fluid that was damaging to vision. But what I think it speaks to is disease control. And I think, again, we can individualize our treatment. But for me, disease control is 50 microns or less of subretinal fluid because I'm backed up by good clinical trial data. And if I have fluctuations that are less than 20 microns or less around that 50 micron mark, I am comfortable with that as well. But I'm interested in Gerald's thoughts and also yours on that question.
Gerald, go ahead, please.
All right, I might go first. I might be slightly more relaxed than even you, Nancy. So I think I would tolerate perhaps 100 microns. I suppose the way I see it is, how much effort are you going to put into chasing that last bit? Now, of course, sometimes if there's a lot of fluid, you inject it and most of it goes, but then there's a little bit left. Now, do you really keep chasing that and continuing with monthly or 6 weekly? I think you can be a bit relaxed about that, but that's my approach.
I'm interested in your perspective, both of you, on how you bring the patient into this decision-making process. Because in my practice, I'm showing patients their scans. They're interested in knowing whether there's more fluid or not. Sometimes the fluid's fluctuating and you can see them becoming a little bit despondent that they've perhaps failed the last period because there's a little bit more SRF. Nancy, how do you engage and what do you say to them to make them feel that we're doing the right things, that is, we're aiming for vision?
So I'm so glad you show your patients their OCT because all of my patients can read their own OCT. They know what fluid looks like. But now my patients also understand fluid compartment, and they all understand that subretinal fluid is not damaging to vision. And what's nice is that the patients actually know how well they see. So they understand that despite these fluctuations in their OCT, their vision tested the same. And so I always do try to let every patient know what their OCT is like and what their vision is like on every visit. And it's part of developing that patient-physician relationship so that they understand the goals of treatment, which is to control fluid, but maximize vision.
Gerald, your final comment with regards to that too.
Yes, I agree with that. Yeah, you're absolutely right. It is the patient's eye, and showing what's going on is extremely useful. I might just add that I do remind the patients that this is a long-term treatment. It's not just 1 or 2, or we're not going to stop, so we have to continue. And once we reach that interval, we'll continue on it. And now it's useful to show them how it changes, how the fluid changes. If they see it increasing from one visit to the next, then they're suggesting, well, why don't we intensify treatment? Becomes a lot easier.
Agree, thank you. I'm just now going to share a few more slides, and that is just to summarize what we've learned and also to discuss this with you, and that we have had local experts put together from the Asia Pacific Vitreoretinal Society, and they have provided a consensus recommendations for treat and extend in neovascular AMD and PCV. And we can see here, these are the broad recommendations. Firstly, to allow the treatment adjustment intervals in increments of 2 or 4 weeks. And this is based on the Altair trial, which has been covered. 2, to allow extension up to a maximum of 16 weeks with aflibercept, and this is on the evidence of the Altair and Aries trial. And Nancy really reinforced that with injecting patients, every 4 months. And 3, to provide flexible retreatment criteria that permits some tolerance of subretinal fluid. Here it's 200 microns, and this is based again on evidence from the Fluid, Altair, and Aries trial. Can you advance the next slide for me, please? Right. And finally, that the aflibercept allows flexible retreatment criteria that permit some tolerance of residual fluid, not intraretinal fluid, and this really has been thoroughly emphasized today by Nancy in her talk. So let's summarize. We've heard during this webinar the role of VEGF and placental growth factor. We know it's well established now in retinal and choroidal disease, but the clinical relevance of Ang2 inhibition potentially may be limited by sustained VEGF suppression, and that is already with anti-VEGF monotherapy. We've seen that with a pragmatic treat and extend approach, aflibercept can address a patient's individual treatment needs through flexible dosing from 1 month right up to 16 weeks. And we have seen also that a proactive treat and extend regimen with the aflibercept can be used successfully to treat patients with PCV as well. At this point, there are 2 points to be made. Firstly, that Nancy and Gerald have given wonderful talks tonight, and really we thank them very much. I'd like to very much thank the audience who have connected here all over the Asia Pacific region, and for Bayer to put together such a educational webinar that is also been very interactive. What I'm going to do now is to remind all of you that there is a poll. And you can see here that there's some feedback questions which will be very important for us to assess how we have done tonight and plan further webinars. And after this, I think this is the end of the show. And wherever you are, please stay safe. And we hope we can get together in a face-to-face setting very soon. Thank you.
So, welcome back. Welcome back. Hello, Dr. Kevin Wong, welcome back. So I think we have a question here about the tolerance of fluid. And I think Dr. Nancy, Dr. Gerald answered that question, but I still want to ask you, what do you consider as fluid, residual fluid, which is stable? Well, what is the stability of the fluid that you can define? And how much is that would you tolerate for your patient?
The first thing I would say to answer that question is we need to use patient's visual acuity to assess tolerance for each individual patient, really. The point of disease control and maintaining vision has been made by all the panelists earlier on. In terms of the amount of fluid, I'll come to that at the end. So for example, if my patients have stable vision with subretinal fluid in wet nAMD, if the subretinal fluid does not increase by more than 50 microns and the vision is unaffected, even with this increase, I would tend to tolerate it depending on the patient's personal needs. For example, in Vietnam, I've tolerated as far as 100 microns increase in subretinal fluid, where the vision has remained stable. But at the same time, I've also injected earlier on where the increase in central macular thickness is only 50 microns. The subretinal fluid is present. However, there's also new suggestions of new early intraretinal fluid. So to have a specific one amount criteria is very difficult for patients in Vietnam. Generally, I'm more flexible. I tend to be more relaxed. I tend to be similar to Gerald. I think my ability to tolerate subretinal fluid in the advent of stable vision is greater. 100 microns is the figure I would cut off myself at, but I would say that would be based on patient's visual acuity. If a patient's visual acuity is dropping, even with 20 microns of increased subretinal fluid, then that would be unacceptable.
Okay, I totally agree with you. When you assess a patient, then you have to take care about not only the structural changes, you also have to take care about the functional changes. So the patient must be stable in their vision or improving in their vision. And secondly, you don't talk about subretinal fluid when you have intraretinal fluid. So you have to dry the intraretinal fluid before you talk about subretinal fluid. Exactly. But when you say about stable, I think it's relatively the same comparing to the last visit, or in the tendency or in the trend of reducing of the fluid. And the number is quite different between trial. For Aries and Altair, for example, it's 50 micron. For Haber, for example, it's 100 micron. For fluid study, it's 200 micron. So I think 100 micron is a pretty safe cutoff. So I totally agree with Dr. Kevin Wong about the 100 micron. So there's another question about the reason why the subretinal fluid is tolerated, and sometimes the visual acuity in that group is maybe better than the dry macular group. What do you think about that, Dr. Kevin Wong?
I think the pathogenesis of intraretinal fluid and subretinal fluid is very different. Intraretinal fluid is ischemic retina itself, inflammatory retina itself, whereas subretinal fluid comes deeper from the pachychoroid. Jemmy Chung, in her PCV presentation recently, has already showed that when there is PCV, there is thickening of the pachychoroid, there is more PED, there's more subretinal fluid. So the actual pathogenesis, the origins of intraretinal fluid and subretinal fluid differ. Therefore, the positioning, the location of the fluid also affects vision in a different way. But do we truly understand why in certain cases, subretinal fluid may even increase final visual acuity despite being present? We don't really truly understand. Only to say that the origins and the locations are different. Intraretinal fluid is definitely a lot more significant effects on vision, and subretinal fluid is not. We consistently see it in PCV, and now we're already seeing it in nAMD as well.
So I agree with that. What you see is the tendency. You see the graph there is a tendency that saying that subretinal fluid may improve the vision, but this is not proven in a clinical trial yet. So that may be a topic for a clinical trial in the near future. So there's some hypotheses explaining this, but these are all hypotheses. Nobody knows whether it's true or not. People say that the subretinal fluid may bring more oxygen and nutritious complement to the photoreceptor. That's why it may prolong the vision and may improve the vision in the long run. But there are also some hypotheses saying that at this moment, we do not have enough time to look at subretinal fluid. Maybe 5 years, subretinal fluid may be damaging to the retina. So all this conflict hypothesis is on the table. We never know until we have a trial for that. So we go on to...
I think the takeaway message for intraretinal fluid and subretinal fluid is that intraretinal fluid cannot and should not be tolerated. Subretinal fluid can be tolerated in the advent of visual acuity not being affected. But if visual acuity is affected, in my personal feel is that both intraretinal fluid and or subretinal fluid should not be tolerated.
Yes, yes. So in the webinar, we also see there are biphasic distribution of the patient when considering the interval treatment. So how do you know which patient needs more intensive treatment and other patient not?
So we go back to what we mentioned earlier on. Visual acuity for the patient is the most important assessing factor. Following that would be central macular thickness, the residual amount of subretinal thickness and fluid collection, whether there's any residual amount of intraretinal scarring and intraretinal fluid. So all of these factors must be taken as a whole, not just one particular factor.
Yes. So there's another question about switching. When do we use switch? Using anti-VEGF, when do we use switch to another more potential anti-VEGF therapy like aflibercept, for example?
This is an excellent question for Vietnam, because in Vietnam, about 70 to 80% of patients start on Avastin purely for financial reasons. Overseas, like in Scotland, in Australia, where there is Medicare, there is NHS, Avastin is taken more like a second step. They go by evidence-based and go by what is best because cost is not involved. When cost involved, I personally am not a pro switcher as well. I prefer to start with the most appropriate medication right from the beginning in order to maximize final visual acuity. But in Vietnam, we're unable to do that for various reasons. For switching, if a patient with wet AMD has been started on Avastin for cost reasons, if the response is progressively, even though it's slow, it's progressively moving forward, visual acuity is improving, fluid is reducing, then you would just continue with Avastin. However, if there is a stop or there is a deterioration, for example, after injection 3 at month 3 of Avastin, the vision reduces, there's a backward step, then yeah, I would consider switching at that point. I would apply my experience in AMD and PCV to sort of my experience in DMO and PCV to AMD as well.
Yes, you can also use the ARIES criteria for the switching. For example, you have persistent intraretinal fluid and or subretinal fluid. You have the best visual acuity less than 20/50, or you gain less than 5 letters, or the treatment interval is always Q4, Q6, something like that. So you have to think about switching to a more potential medications. So far, do you have any experience with the safety signal for aflibercept?
I think safety profile for aflibercept is very good. Compared to long actings, it's definitely much better. On top of that, it also blocks PGIF, which is an important factor in developing wet AMD. I think so far, with the years that have gone by and multiple clinical observations, clinical trials, RCTs, we know that aflibercept is very safe and very effective to use. So I have no safety concerns at the moment with aflibercept.
Yes, I do believe there's no really concern about safety profile for aflibercept in my practice also. And I see that there's no more question from the audience. So I would like to wrap up the conversation. And I would like to thank very much Dr. Kevin Wong, who is with us today. And we hope to see you in person very, very soon, because you contribute a lot to our community, our ophthalmologist community. Thank you very much.
Thank you very much for your kind words. Before we wrap up, there was one point that was not covered by Gerald about PCV. In patients with PCV, they have a PED and subretinal fluid. In his example, the PED was treated to flatness, let's call it. PED is essentially not fluid, is thought to be a non-closure of polyp. However, I've had more than a few cases of patients with poor visual acuity initially with subretinal fluid and PED, With treatment of intravitreal ILIA, the subretinal fluid dissolves. However, the PED reduces in size, but never really disappears. Visual acuity does improve, as was shown in Gerald's case. Maybe not to 6.6, but he got the patient to 7.5 with residual PED. These patients, if they have access difficulty, if they have financial difficulties, if they have difficulty coming for regular follow-up, they can be left with a small PED and still maintain vision. On my books, on my patient notes, I already have 3 patients in my clinical practice that still have PEDs present, but there's no longer any subretinal fluid, and the vision is maintained at 6.6. So coming back again, you treat the patient, you treat the vision. You don't necessarily have to treat the structural abnormality. The structural abnormality, by definition, in the past was a guide. Now we know that the guide is not necessarily applicable in our daily practice. So with PCV, another important point that I would like to make is that you do not need to treat until the PED completely disappears. If PED disappears and then returns, patient's visual acuity remains stable. You still can apply the treat and extend patients out to 16 weeks. My 3 patients that still have small PEDs, they're now out at actually more than Q16. They're out at Q20. 2 of them are out at Q20 and 1 of them are out at Q16 with PED present. I give them an Amster grid. I ask them to stick the Amster grid on the fridge because that's what we do. We open the fridge door all the time. I get them to check for distortion once or twice every day. Every time you open the fridge, just take 1 minute, cover one eye to check the distortion. If they have distortion, they know to come back immediately, but they are already on Q16 and Q20 intravitreal ILIA, which is a big thing for them.
Thank you very much for your input. Bây giờ tôi xin qua phần tổng kết một số cái điểm chính mà trong cái buổi hội thảo chúng ta đã vừa nghe trong suốt hơn 1 tiếng vừa rồi. Thứ nhất là về cái thuốc chúng ta bàn trong cái buổi hội thảo ngày hôm nay là aflibercept, thì cái vai trò của nó rất là quan trọng là bởi vì nó ức chế được cả VEGF và PLGF, và chúng ta biết là PLGF nó có cái vai trò kích thích cái VEGF receptor số 1. Đấy là cái một trong những nguyên nhân chính để gây ra cái chuỗi viêm, xuất tiết cũng như là tân mạch ở trong võng mạc. Thì nếu mà chúng ta sử dụng thuốc có tác dụng kéo dài và cái ái lực cao với VEGF như là aflibercept chẳng hạn, thì chúng ta có thể giãn cái khoảng cách để chúng ta điều trị trong cái điều trị treat and extend đó, chúng ta có thể giãn cách mỗi 2 tuần hoặc là giãn cách qua 4 tuần, và cái tần suất mà chúng ta tiêm thuốc có thể giãn tới 4 tháng. Thì trong cái bài báo cáo của bà Nancy mình có thể thấy là trong các cái điều trị, các nghiên cứu treat and extend đó, thì 2 cái đỉnh để điều trị cho ranibizumab và bevacizumab là 4 tuần và 12 tuần. Tức là có rất nhiều bệnh nhân cần phải điều trị mỗi 4 tuần, và nếu mà giãn ra được thì là mình giãn là ở 12 tuần. Còn trong cái biểu đồ của aflibercept thì chúng ta thấy là cái con số này là 8 tuần và 16 tuần. Tức là nếu mà điều trị liên tục thì nó vào tầm khoảng mỗi 8 tuần. Còn nếu mà điều trị giãn ra được nhiều đó thì nó có thể tới 16 tuần, tức là 4 tháng với thể tiêm 1 mũi. Còn điều quan trọng nữa là aflibercept rất là hiệu quả trong điều trị PCV, và cái hiệu quả điều trị PCV này nó không khác gì so với các cái AMD khác. Thì đấy là những cái điểm chính quan trọng nhất trong cái buổi hội thảo ngày hôm nay. Thì xin mời quý vị là nán chút thời gian để làm một cái khảo sát chất lượng, để hy vọng là trong tương lai chúng ta sẽ có nhờ đóng góp của quý vị, chúng ta sẽ có những cái buổi hội thảo chất lượng hơn, và chúng tôi hy vọng là trong tương lai gần sẽ tiếp tục được mời bác sĩ Kevin Wong sẽ tham dự cùng với chúng tôi. Chúng tôi xin trân trọng cảm ơn Trung tâm Mắt Quốc tế Phương Đông, Trung tâm Mắt Hoa Kỳ và công ty Bayer, cũng như là bác sĩ Huỳnh Võ Mai Quyên là người phiên dịch. Ngày hôm nay thì bác sĩ Mai Quyên là người cực nhất trong buổi hội thảo ngày hôm nay. Thì lúc bác sĩ Quân chém gió hay là những người khác chém gió thì bác làm việc rất là cật lực. Xin cảm ơn bác và hẹn gặp lại bác Mai Quyên trong buổi hội thảo lần sau. Xin cảm ơn.